Hello, everyone, and welcome back to Bright Spots in Healthcare. This is Eric Glazer, and this episode is once again produced by Bright Spots Ventures. Our mission is to spotlight what is working in healthcare and help figure out how to scale it. We bring leaders together from across health plans, health provider organizations, and other innovative solution providers to share strategies that create real world impact. If you have not yet subscribed to the podcast, and you want each episode downloaded to your device, take a moment right now, search for Bright Spots in Healthcare in your favorite podcast app, and simply hit subscribe. It allows more of your peers, more leaders in this industry to find these conversations and then take the ideas in these discussions and apply them at their organization. And that's how we fix or improve healthcare in our lifetime. So by subscribing, you're doing a little part in hopefully helping the industry get better at what we do. All right, today's conversation, it's about something deceptively simple, but incredibly hard inside Medicare Advantage organizations, and that is knowing what is actually working. Health plans are running disease management programs, transition programs, pharmacy outreach, we've got digital engagement, vendor initiatives, and activity is high, effort is high, but clarity is not always high. And that challenge shows up in a lot of other industries too. So I like using Netflix a lot as an analogy. They don't decide, that you're just an action fan or a fan of comedy and stop there. They actually continuously analyze signals, right? So when do you start a show? When do you finish it? When do you abandon an episode? When do you rewatch it? Even the time of day of when you watch, your profile evolves based upon the behavior and motion, right? That's why we have such a good experience when we use it. If they relied on a single annual classification, then the recommendations would become fairly irrelevant pretty quickly. I watch a show with my wife like Scandal, and I'm stuck with all that stuff, but they're watching me continuously. And so they have a much more comprehensive view of what makes me tick. But in Medicare Advantage, we still operate, right, in population stratification. Members are segmented once a year, outreach is launched, and then the volume is measured. Meanwhile, members are constantly changing. Their risk shifts, their motivation shifts, their life circumstances are continuously shifting. So the real question is not how much engagement we generate, it's whether we're detecting and responding to the right signals in real time. And that shift from segments to signal is the lens for today's conversation. Now, discussions like this, we've been lucky to have started the show back in 2014, and we're only able to do this because of the support of organizations that believe that healthcare improves when leaders openly share what's working. So today, I'm really excited to introduce a new partner to the Bright Spots in Healthcare family who supports these discussions and are going to help push our industry forward. And that organization is MedOrion. And they work with MA plans to integrate clinical, situational, and behavioral data so they can identify which members are realistically movable and prioritize outreach more intelligently and coordinate action across the organization. So you could check them out at medorion.com. I'll spell that for you guys, medorion.com. I'll tell you a little bit more about them later on in the episode. Great partner, great organization. Check them out. And joining us also today are leaders that are working on this shift, right, from operational perspectives across their MA products. So I will introduce them. First is Mike Leapier. Mike is the Director of Government Quality Programs at Highmark. We have Brendan Generelli. He's the Director of Medicare Stars and Quality at Johns Hopkins Health Plan. We have Amin Sarahali. He is the Senior Vice President and Chief Data Analytics Officer at Independent Health. And representing MedOrion, our partner today is Dave Burianek, and he is the Chief Strategy Officer for Health Plans at MedOrion. So thanks, guys, all for joining us. If you're watching live on Zoom right now, we'll post a link. Actually, we just did a link to these guest bios so you can get a sense of some of the great expertise you're about to benefit from. And we'll also put it in the show description if you're listening via the podcast. All right, let's start with the core discipline behind all of this, and that's knowing what's working and knowing what's not. So, Mike, I'm going to start with you. When you look across MA, there's no shortage of benefits and programs. But when you dive into the data, are they producing actual results? So I'd be curious, how does Highmark decide what benefit program is actually worth leaning into and what you take away?
Yeah, thanks Eric for having me today. It's a big problem that I think many of us that work in the Medicare Advantage star space face, given sort of the extent of programming and interventions that take place, whether through a provider interaction, whether it's from a care case disease management within the health plan. Then you layer in all sort of the touch points and activities we're doing to try to impact things like the CAP survey and the HOS survey. There's a bunch of things happening all in parallel. And so it's a challenge. It's a challenge to do, but it's something that like I would say is an imperative for what we at Highmark and our stars team has been trying to do and continue to do better. It's particularly in the last couple of years with the changing of the measure weights and everything and the shifting of priorities from a CMS perspective. We really have to figure out like what are the programs that we think are having the biggest impact or not. And it's just a lot of tough work. It's working with the program teams, it's working with the clinical teams that maybe sit outside of our organization that are doing things not for the purposes of stars, but can have a benefit on our star ratings and for particular measures. So we're doing a lot of work to figure out like how do we get to the data across all these teams that help us figure out who are they engaging with, when are they engaging with them, what is the purpose, what is the length of the engagement. And then I'm blessed to have a team of actuaries that support me and do a lot of the heavy math and the heavy lifting on the analytics to say how can we derive insights into what is driving outcomes for a particular measure or a particular set of measures. So that's what we're doing right now. We're really trying to shift, and look at programs and figure out like what are the things that are having the biggest material impact? What are the nice to haves that maybe we need to scale down under the cost pressures of Medicare Advantage? And what are the things that are like no regret programs that like even if we can't get a direct quantifiable impact, they're easy to execute, they're low cost kind of efforts. And so we're trying to constantly right size the set of programs and interventions that we're executing under that landscape of what's working, what's the cost, and should we ramp it up, should we ramp it down? That's kind of the mindset that we're looking at programs.
Do you have an example of a specific, you don't have to mention a digital platform or even a partner, but
Yeah.
like an example of how you're looking at maybe one of those benefits that you've integrated into your portfolio of offerings and how you look at them and how you decide whether to keep or to remove?
Yeah, I would say we had a program that we're diving into. Um, that's really related to how members get care after their discharge from the hospital. And we're finding some interesting things that the team that built that program and implemented that program didn't do it for the purposes of stars. It was more developed under the purpose of care management, helping members, right, managing care costs. And there's been sort of like this perception that like there's questions about how effective it is from that lens only. And so we're trying to layer in a star lens now to say like we have this big triple weighted measure preventing readmissions that we have clear data on. We could see who they engaged with, who they tried to engage with and didn't engage with, and then we're able to see the implications on readmissions. And really, what we're doing is we're trying to shift the narrative in how the enterprise is looking at a lot of our clinical programs to not only think about what is the impact on sort of like care costs, but what is the impact on the star measures themselves, and that as they're reprioritizing what the limited number of nurses do and don't work on, that we don't forget about the impact on the quality scores, the star ratings, and a revenue lever, in addition to like how might it be impacting care cost of members over time.
Nice. I want to talk a little bit about quality and and how we identify individuals that are about to be a little bit more complex or have risks of being more complex. And so I'm going to bring in now our sort of chief data and analytics guest here. I mean, Sarah Hawley, who's been a little bit busy dealing with a bit of a merger acquisition. He's at Independent Health. And so, I mean, welcome. And what is Independent's approach now to surfacing risk early enough to identify those members in your MA programs that are about to spike and maybe intervene early? You are on mute.
I still haven't figured out the mute button yet, as you can tell. Well,
Me too. Me too. And I've been doing this for 12 years. So,
well, thank you for having me. I'm going to start with describing how we approach what we call rising risk. So first, we actually license the MARA tool from Milliman. And Milliman has a really good way of identifying the risk. So for the rising risk, we get, here's the current risk, and this is where we expect the risk to increase or decrease by. So the risks, the current risk is going from 1 to 8, and the rising risk is going to go either from -4 all the way to 4. So for example, somebody who's right now at risk 2 can go up to 6 and actually can come down to 1. So we're trying to understand not just the rise in risk, by the magnitude of that rise. And that's the first piece. You identify the risk, but that's not enough. So we're trying to understand, well, to make it actionable, well, why are you rising? And now we need to start layering a lot of other data. So quality, utilization, engagement, all that good stuff. Because at the end of the day, we have to identify what is the right action for this trigger that we're seeing right here. So to make this, to give an example here to explain this, we take a look at what are the drivers of this rise. What are the clinical drivers? What are the top, for example, 3 clinical drivers? Let's say we're going to see CKD is one of them. We're going to bring down, this is an example that actually, we dealt with internally. Okay, we're looking at the people that CKD is the main driver of the cost increase for next year. Where are they right now? Oh, there are CKD2. Now we're bringing more data to say, well, are they taking their medication? Oh, there's some people that actually are not taking blood pressure medication. We're adding lab values and we're finding, oh, some of these people have high blood pressure. And, oh, have they seen a nephrologist? No, they have not seen a nephrologist. So we have to put all that picture together to come back to say, well, of this rise in risk, what is it that we're going to do? What is the best action? And now to layer on top of that, well, who's the right agent to work on this action? Because we can identify, oh, for this segment, it's rise in risk. Actually, if they take their medication, these are people not taking their medication. Well, we just need to put them on. They need, on blood pressure medication. Well, this probably needs to go to our pharmacy team or needs to go to our care management team. But it's something that, well, they're not seeing a nephrologist. Well, who does, we need to talk to the PCP about doing that referral. So that's how we bring it all together to not just from identifying the rise in risk, but what should we do about it?
And what's the actual insight once you get that? How quickly are you able to turn that around and do something with that? I mean, like maybe like a real example of.
So honestly, it depends. Do we have the data or not? When we have the data, we can turn this around very well. We have over the years, actually, we built a very solid member 360. So we have this schema called the care coordination or the member 360 schema, and we have really improved our velocity or the timing for us to act. When it takes time is honestly when we have to capture data that we don't have.
Got it. Got it.
Now, I forgot one more thing. We also layer on other risk factors. What are the risk of going to an ER? What is the risk of an admission? What is the risk of a fall? What is the risk of this? So we have a lot of other risk models or predictive models that we layer on top of it. So we're looking at it from a disease perspective, from a clinical perspective, what's the driver of that risk? But we also look at it from a utilization perspective. What are some of the events that that we don't want to happen? What's the probability that somebody will be readmitted or be admitted, and so on? So all that goes into making that what is the right action for this person that's expected to rise.
Got it. So I want to transition now from, okay, now we know, and now like, what's the experience we want to provide those members? And I mean, I'm going to ask you a favor of just putting yourself on mute with the risk of you coming back. I just think I hear a little bit of feedback coming from your side. So I'm going to ask Brendan. He's at Johns Hopkins Health Plan, Director of Medicare Stars and Quality. Brendan, how have you guys revamped how your members receive information and get connected? And walk us through sort of what drove any changes that you've made and how, and maybe explain today's member experience.
Sure. Yeah, thank you for having me on today, Eric. And it's always a tough act to follow Amin and Mike in any conversation like this. They're both such strong leaders. But yeah, we at Johns Hopkins Health Plan, one of our core beliefs is that Medicare stars and quality as a whole needs to be a core competency of the plan. Every person who works at Johns Hopkins impacts quality in some way, even if you don't directly work in the Medicare line of business. Something you do impacts stars. So, one of the ways that we really bring that to life is we like to do a lot of cross-functional collaboration and work across teams across the organization. And one of the, real examples of some of that work that we did recently was we brought together the Stars and Quality team and the member experience team to, start collaborating on member journey and how members receive outreach over the course of the year related to, quality topics, whether it's reminders to get screenings, whether it's reminders about vendors, whatever it may be. This was really driven by an example that one of our executives brought in. She was speaking with a member out in the community who said, hey, over the past couple of months, I've got 43 letters from you guys. That's a lot. And I'm sure all 43 of those touch points were incredibly important for the area that was trying to make that outreach. But that's a lot to deal with, in one mailbox. So we wanted to take a step back and really understand, the intent of these communications, who's reaching out to people, why are they reaching out, when are they reaching out. So we convened a cross-functional group. So like I said, this was an effort led by the Stars and member experience team, but we brought in folks from our product team, our pharmacy team, care management, utilization management, grievance and appeals, customer service, compliance. There were probably more that I'm forgetting, but a broad swath of the organization to really, in a very analog way, map out the journey of a member over the course of the year. We gave everyone post-it notes and said, hey, what are you doing in January? Put up a post-it note for an email you send out, put up a post-it note for a mail piece, put up a post-it note for a phone call, and so on. And we ended up with a beautiful rainbow of post-it notes. We then took it, that next step and said, all right, well, hey, let's identify some common themes that we see in these communications. If the pharmacy team is making outreach to someone about mail order, but we know that a customer service rep is going to make a welcome call to a person, can we combine those two? Can we make part of the welcome call, be a transition to mail order, for instance? And over the course of the year, what we noticed as we were looking at, again, this beautiful rainbow of post-it notes, is that while these were all really important messages going out over the course of the year, they didn't really have, a coherent story to tell the person along their journey of health. So we started, working with these different teams to find that cohesiveness, and then started refining it even a bit more to say, well, hey, if we're talking with members in the first 3 months of the year, I know for stars, I have caps to focus on. We want to drive something that drives a positive member experience and make sure that people are set up for the year with their benefits, that they're set up with their annual wellness visit, whatever it may be, that they need to do early on in the year to impact those caps measures and set them off on the right foot. In spring, let's talk about spring screenings. Um, get your tests done, be prepared so you can have a healthy summer enjoying the beach in Maryland. In summer, it's about maintaining that health, staying healthy while you're at the beach with your friends and family, and doing the things you love. And then in fall, well, besides a Don't Fall in Fall campaign, because, I'm a Medicare Advantage plan, we all have those, but also setting that tone for what's next. Hey, the holidays are coming. You want to be able to tell your friends and family at the holiday season that you took care of yourself when they ask you, did you go to your doctor? Did you do these things that I see ads for on TV to take care of your health? You want to have that pride and ability to tell your friends and family, yep, I'm doing what I can to take care of my health. And I'm setting up a resolution for next year to be even healthier. So, through this whole program, we really created a great understanding of the member experience. We were able to cut back on significant amounts of sometimes duplicative outreach. And we really set ground rules for how we are looking to coordinate and engage with the people we serve going forward.
So that's fantastic. So one, you obviously got everyone rowing in the same direction and sort of centralized communications. So we weren't getting 43 communications per. The second thing you did is you tapped into sort of, and I'm not a psychologist by any stretch, but you sort of tapped into the psyche of the individual members so they not only could get proud of sharing what's going on with themselves, their lives during certain times of year that are particularly relevant, but also do it in connection with their family and their loved ones. And so you're almost creating this almost unconscious kind of feeling of accountability and driving sort of, so not just driving a one and done engagement, but driving meaningful, continuous engagement in a relationship between you, you as the health plan, the member, and then the members' stakeholders.
Absolutely. Anything that we can do to help, help a member feel that pride and feel that ownership of what they're doing. It's not the health plan telling you to do something. It's you doing it because the health plan is helping you meet these needs.
Help me help you is what you're saying to them. Is there any, I don't want to put you on the spot, but I will. Do you have any quantitative data to suggest like the impact so far, or is it still too early to tell?
It's still very early. I can tell you we're certainly not sending out 43 mailers anymore. That rainbow has started to shrink. But we're still very early in this. We're continuing to monitor the impact. We're continuing to take a look at both the financial savings and the member experience. But one thing that I can say is, some of our very early, January 2026 digital outreach, we've seen very impressive click-through rates because we're now reaching out when it's meaningful in a way that is meaningful to members.
Yep. Sure. It makes perfect sense. Let's tie it all together now. I mean, we're not closing here, but like this last little dialogue, I think we could tie it all together and bring in sort of identifying early, using the data and engaging. And so I'm going to bring in Dave Burianek, and Dave again is the Chief Strategy Officer for health plans at MedOrion. And Dave, how are plans, because we've heard a lot of really interesting insights from our three guys so far, like how are plans beginning to leave the checkerboard and start playing chess, to start applying the data and, applying almost that 80-20 Pareto's law to their strategy, so they're using that 80-20 method to improve HEDIS caps and Medicare Part D.
Yeah, thanks, Eric. And Brendan, when I was a senior leader at the health plans, that kind of brought back some memories of when we were asked to go into individual members' homes and see what communications actually they got. And they'd bring out big file folders of, guess what? Here's everything you've been communicating to me. So it kind of brings back those flashbacks of, oh my gosh, we still have that problem. That's still out there. But, Eric, to answer your question, I guess the first thing that I would probably say is that, I don't know if it's about playing chess. I think from a health plan perspective, we have a lot of Paretos. I don't know that I've ever had a shortage of Paretos in doing the 80-20 rule to figure out, where is it that you most likely need to go next or who you need to work on. But I think, we're at the point where in order to meet the CMS goals and really to get to be at that 4-star, 5-star plans, you have to fundamentally transform our thinking and how we're doing things. And from a MedOrion perspective, our goal at the end of the day is to help plans drive impact to the members to ultimately, get the care that they need and raise the star scores, right? So, as I think about interventions at the end of the day, right? You have your member interventions that you do, you have provider interventions, and ultimately you've got to drive, attainment of the data to prove that all those things are working. So I guess the best way that I could probably demonstrate or exemplify kind of what a new way of thinking is from an example on a plan that we've been working with. And the situation was, in measurement 23, rates published in 24 called the 25 star scores, right? Their targets landed below their expectations, right? And below the domains. Typically, they've been 4.5 star plans. Part C now dropped to 3.5. Part D dropped to 3.5. And the overall contract dropped to 3.5. 60,000 member plan, Southeast, United States, and they were at that point trying to figure out, all right, what the heck do we do? A lot of change going on in the industry. And what some of their problems were was, they were looking at all those domains as silos, right? Their pharmacy people would look at their pharmacy measures, their HEDIS people would look at the HEDIS, caps would be a whole different thing. And, Brendan, that's how you get those 43 letters, right, at the end of the day. And, compliance and process requirements, slowed down execution. So, and they were pretty, conservative. So that led to, limited use of technology, whether it's emailing, texting, social media, IVRs, those sorts of things. And those member outreaches at the end of the day were really focused on campaigns, right? What are we going to do in the first quarter? Great. Let's send everybody communications about caps. What are we going to do in the second quarter? Gosh, this is around, annual wellness visits. Let's communicate there. Third quarter, you're starting to get to the end of the year. And now we really need to focus on, colonoscopies and those that are going to have, the longer lead time cycles. So what they ultimately came around to was really looking at it and thinking on fundamentally how can they transform the business. So they took 13 measures across HEDIS, pharmacy, caps, and they did 3 things, right? One, to your point, they started looking at the data and building that member 360, but they built the data, working with their vendor partner across pharmacy, grievance, complaints, social determinants of health data, and more, right? And they did this not just to look at the gap, right? Not just to look at the clinical data, because I think from a health plan, we always think about, okay, clinically, what do we want that person to do, right? But also looking at it from the signals that were generated. So signals being, situational, right? And at that point, it's, what's that member going through? Are they too busy to be able to do things? They looked at it from a clinical standpoint, right? Coming in with new diagnoses. looking at it, and also looking at it from a behavioral standpoint. How are they feeling? How are they perceiving it? So they were really focused on those three different type of signals at the end of the day in terms of accumulating that data. They then shifted from rules-based outreaches, right, to campaign-driven, to really behavioral informed micro-segmentation using phenotypes, right? Words that we all use in the normal language today. What that really kind of means, and when I think about phenotypes, it's about really understanding the barrier and the sub-motivations behind that barrier. So an example, right, logistics. A lot of reasons why people can have a logistics issue for why they may not be picking up the meds. Phenotypes would, the barrier would be logistics. The phenotypes would be, gosh, I live far from the pharmacy. It takes me 2 hours to drive. My meds aren't synced. That's a logistic issue. I don't have a car, right? And I can't drive, so I just can't get there. And then, there may be some physical limitations of being able to do that. So, solution home delivery, but communication wise, lots of different ways to drive communications to make it most effective for that member, for that particular, gap you're trying to solve. So again, really, building the data, assembling it to the form of looking at the different signals, situational, clinical, behavioral, and then ultimately having a quarterbacking or a governance system that synchronizes all those different, 13 measures and everything that you want to do on a near real-time basis, right? Being able to then outreach at an individual level against those different barriers that you're trying to solve for based upon those different signals that you're reading. And they tracked it all at the end of the day, both the macro piece and all the micro segments to figure out what worked, what didn't work, how to continue to tweak, different messaging. And again, at that individual level, rather than, campaign-driven, persona-driven approaches. And at the end of the day, they also took this data to flow it to provider groups to make sure that from a care coordination perspective, they understood what was going on. They flowed it to their internal operations, call center groups, care coordination, because they really wanted to make sure that, everybody was in the sync of what was going on and how it was going. And at the end of the day, right, they saw their med adherence scores improve 2 to 5%. Based on the measure, they saw their CAP scores going up with annual wellness visits increasing. And they ultimately saw their Part C scores get back to 4, Part D scores get back to 4, and the overall contract, reaching the 4 stars. So being able to really drive that micro segmentation to enhance the communication at that member level and really build that deeper understanding of the members.
That's a great story. There was a lot there. Let me see, Dave, just so everyone can get it one more time, and I'm going to do a quick summary here. So 13 measures, 3 signals. That led to microsegmentation using the new phenotypes. That led to you understanding the barriers and the sub-motivations. Then you're able to outreach at the individual level. You review the outcomes and the feedback. You refine it, and then you do it again. And meanwhile, at the same time, you're doing a good job. The plan's communicating across all the stakeholders internally and through the provider groups that they work with, what's going on and how it's working.
Correct. Absolutely. Yep. And look at across the channels, right? What's the best way? Is it emailing? Is it texting? Is it, printing? Is it a phone call? And being able to help prioritize it that way as well. So how do you reach that member at that point in time when they need that message most direly?
Yeah, that's fantastic. I know what you just described. I know more and more organizations and people listening who represent organizations who are trying really to align their engagement with who's realistically movable, and just it's a shift across and an imperative shift for everyone in MA. So it strikes me, guys, MedOrion just outlined and created a report called Segmentation to Signals Engagement that not only addresses but anticipates member barriers. And so if you want a copy of that report, and it explains how signal-driven engagement brings clinical and situational and behavioral data together we can allow you to get a copy of that. It's an easy read. It's a full report. It's a PDF. Just let us know on the poll, and we'll get that over to you. And like I said, MedOrion, they're experts in this area, so they could really they really understand these signals across quality pharmacy care management and everything you just heard from Dave. So let us know. We'll send you a PDF. I'll come from me in the next 24 hours if you want a copy of that. All right. So at the end of the day, when we're talking about engagement, we're talking about now different categories are tied to Medicare and Stars. I mean, pharmacy measures are shifting and the cost barriers are changing. So how are you rethinking your approach to adherence specifically and just in general now? How is independent health adjusting your overall pop health strategy? Oh, you're on mute again. I'm sorry.
Man, still haven't learned.
Yeah.
Well, I think you asked two different questions there. Let's start with medication adherence. So yes, CMS is going to be risk adjusting the medication adherence. And honestly, to win, you really have to understand. You got to get to the detail. You got to understand how this model is going to work. So let me just walk you through it really quick. So just imagine a file with 3 columns. You have your member first column. The second column is just a 1 or 0 indicator if the member reached that PDC of 80% or not. So 1, 0. And the third is the outcome of the model that CMS is doing. So it's a probability between 0 and 1. So what CMS is going to do is going to take the average of the second column, your 1 and 0s, how many people reach that PDC is going to be the numerator. The denominator is the average of the probabilities. These probabilities coming from the model itself. And I'll talk about that in a second. That's going to be the denominator. It's going to take the numerator divided by the denominator, and it's going to multiply by the national average. So how do you win? You win by making that numerator high. You want as many ones as possible. And you win by making the denominator low. So how you make the denominator low? So the model has, so there's age, there's gender, I think they're going to combine dual eligible and LIS, and disability. So really, if you think about it, this model has 4 parameters and it's going to have 5 betas, right? Five coefficients. So the first coefficient, beta 0, basically just your intercept. Somewhere is going to be around like 1.2, some 1.1, 1.2, and everything else is going to be negative. Well, I'm sorry. If gender is male, if the model male, of course, it's going to be negative. So as you age, the coefficient for age is going to be negative. If it's male, the coefficient is going to be negative. Dual eligible or LIS, that's going to be probably the highest beta factor. And last is the disability. And these two, the last two, are going to be the highest factors. Now, why am I talking about all this? Suppose that Amin is actually an LIS, and I did not identify Amin as an LIS. So the model is going to say, let's say that factor for the beta for LIS is minus 0.35. It's going to take minus 0.35 multiplied by 0. So, but if I identify Amin as an LIS, it's going to do minus 0.35 multiplied by 1. So I'm starting from an intercept that's 1.02, and I'm going to be subtracting minus 0.35. If I fail to identify patients that are LIS as LIS members, I am making that third column as high as possible. So first, you really have to identify who do you want to go after. So the first in this, with all these changes to win at this, medication adherence now with risk adjustment, I'll say the first thing you have to identify your LIS members. I've seen honestly a lot of plans already moved from the broad segmentations. So for adherence, so people are using analytics to do more targeting, who's the people that are likely to be recoverable. What I will say is just don't layer risk on top of that. Yes, you don't want to go after everybody, but you don't want to admit somebody who's, for example, at a 40% PDC rate, there's no way they can get to 80% at the end of the year, but they have an A1C of 12. You don't want to just let everybody go. So yeah, some people that are low risk, but you're not going to get to at the end of the year, maybe you can let them go, but there is you got to bring in the risk. You got to bring in some of the lab values. Somebody who has a high blood pressure, yes, it's not going to get to the 80%, but you really want to manage them for other things. So I think we are seeing already people moving into identifying people that missed the refill within 5 days, where people are following the PDC slope, and looking at how the slopes are changing over time. Somebody who has hospitalized. So I really seen already people moving from a high risk to an actionable risk. How you nudge, we are in, I think, in the business of trust. So really, if you think about it, the reasons for, or the drivers of non-adherence haven't changed much. So there's some people that unintentional non-adherence because cognitive issues, access, transportation, complexity. There's still cost. Even most of these drugs are generic, but for diabetes, some of the drugs now have higher costs. And you can and by switching people to LIS, actually you can take care of them. Side effects always been there, always will stay there. And there's now some people don't want to believe in science, and of course some people don't believe in the benefit. Well, if somebody doesn't want to take a COVID shot, I don't care how many times you're going to tell them to take a COVID shot. Don't even do that. You're going to even lose trust. So how you nudge, I think we have to, and what I said before, you got to align the action with the right agent. If it's cost, it's, do some LIS counseling, maybe look at your formulary. If it's access transportation, what transportation services are in your community? Side effects and low perceived benefit, I don't even think that should come from the health plan. I think that should come from the pharmacist or from the doctor, the PCP. So that's kind of what I'm thinking about it. Like, we really gotta kind of shift a little bit to a more intelligent, and not just to get a temporary PDC lift, but we're really looking for, because if you think, in 2027, 2026, now these measures are, the weights are only one. In 2027, they're all going to go to three, right? So really what we're looking for is how can we have a sustainable PDC, not just trying to solve it for this year.
Okay. That's great. I'm gonna jump in here. I'm just looking at the clock. I know we're really tight on time right now, and I want to make sure we get a couple of other questions around caps in. So apologize, but I want to jump into caps for a moment and bring back in Mike Leeper. He's the Director of Government Programs at Highmark. Mike, many plans now are sort of navigating all this disruptive product and network changes. When experience now becomes under pressure, right? A lot of you guys are losing caps scores because of this. How are you staying connected with the members and maintaining a gauge on how they're feeling in real time as all these changes and disruptions have happened?
Yeah, that's a great question, and that certainly represents the current landscape of Medicare Advantage with the financial pressures on what's being reimbursed, the claims trends, right? I'd say the tightening of the risk adjustment levers and even the star levers, and how that helps cover the cost of benefits and services for the member. So Highmark is not immune from that. And so we just went through an enrollment cycle that we had to purposely I'd say reset our product and benefits to ensure viability in the Medicare Advantage space. We want to remain committed to that market, but the financials required a reset. And as a star leader at Highmark and thinking about like what is this going to mean for caps, right? It was sort of an unprecedented situation since I've been in the stars world. So a lot of questions around what's it going to mean for caps, what like how is this going to impact CTMs, all that stuff. We obviously modeled a bunch of scenarios, but a lot of that was based on hypothesis. And so, fortunately, I heard several people talking about bringing people together, rowing in the same direction. Very fortunate that the team that is responsible for caps and member experience, member journey, is also the team that's responsible for member retention. So they have a high appreciation for the caps implications of the situation of when you reset benefits, and how disruptive that can be for members. So we took the approach that, like, unlike a normal open enrollment year where the marketing and sales is how many members can we retain, how many members can we gain, like there was a recognition that like this is going to be disruptive. How do we make sure it's in the members' best interest to understand what is changing for them so that they know consciously, do they want to stay? Do they want to find something different? Can we find them a better fit plan with Highmark? And in some cases, we knew going in that like there just may be a better fit outside of Highmark for members. And fortunately, at the same time, we had already been partnering with a partner that I think many other health plans work with to help give us insights into member sentiment, specific to caps. I would say we were already accelerating the pace at which we're polling and surveying and doing impression surveys, and not dependent on the old traditional sort of like do a big caps fall simulation survey to get a sense of like what you think member sentiment is, because the timing of those don't work with when members are finding out and or starting to experience the changes of their benefits. So we've increased the frequency at which we're doing pulse surveys. We're trying to get more real-time member sentiment so that all the great work that the outreach and the marketing teams are doing to educate, inform, navigate members through maybe needing to shift doctors, maybe needing to change plans, understanding changes to benefits, that we can pivot in a more rapid pace than we have historically. And I think like that was needed without disruption, but the fact that like disruption was happening made it even a bigger priority for us to do. Again, it's the right thing to do for the members, but also has a significant impact in where your cap scores go. What I continue to tell teams at Highmark is that caps is about like managing member expectations, right? If they get surprised in a bad way, that is way worse than if you do a good job up front of like making sure they understand how do their benefits work, which doctors can and can't go to, and if they have that expectation and you manage it well, it typically leads to a better caps outcome. So that's kind of where we're at in that journey in the midst of disruption. Fortunately, I have partners that are very intentional in understanding the impact on members and wanted to do the right thing by the members and not just focus only on the retention numbers. So
yeah, that's great. I mean, if we weren't so tight on time, I have a couple follow-ups. That was really insightful. I'm going to keep on pressing on. Two things, folks, real quick. We always ask for your feedback so we can modify formats, add things to the experience that you're all having watching this show live or listening to it via podcast. So if you could take that survey that Nicole put the link in the chat, but she also will email you a copy of it, or it'll come from me, I guess. Taking a couple minutes to take that survey is really helpful. To that end, a couple years ago, one of the things that folks requested was, hey, we'd love to be able to register with one click while we're, for upcoming episodes. So we've curated 2 episodes coming up for you that we think will be terribly relevant for you both, for everyone listening. One's called Care Without Proximity, Winning Moments Before Care. That's happening on February 26th. And the next one is AI and Specialty Value-Based Care, happening on March 26th. If you guys want to come to either or both of those episodes, we will register you for those. If you click on the poll, we'll pop one up for you. All right, Dave, let's stay with CAPS for a moment, because CAPS is often, a survey problem, but could you share an example of a health plan when a health plan starts, treating it as more of an experience problem instead?
Absolutely. And first, I would just want to say, looking at those measures in total versus in silos, right? Med adherence versus A1C, critically important, right? Especially in these times when you've got to move the needle on everything, and looking at those different situational, clinical, behavioral signals are really a key to being able to get there. So, Eric, to your question on CAPS, right? And Mike, from what you were talking about, no surprises at the end of the day. And especially as we go through the end of, the years, right, with all the different changes, and especially this last one was probably one of the most disruptive, I think, that I've seen out there. Being able to really work through that is critical, and making sure that members are aware of the changes, and being able to minimize that disruption, right? A lot of folks have predictive models on who's most likely to score poor on CAPS, doing the mock surveys, those sort of things, which are fine, but really going into and understanding how you can offer to help members at the end of the day is critical, especially by looking at all those different signals. So, one of the key thoughts that I always remember is, people really forget what you say, but remember how you made them feel at the end of the day. And offering members help in these things that may be challenging is really critical. So when we worked with the plan, the plan did really 4 different things, and somewhat basic, but took work, right, getting them through the organization. One was try to proactively identify gaps in experience based on those signals. Try to identify areas at the time they're estimated to occur, the areas of escalation, like, calls at the beginning of the year because benefits changed, right? And didn't know when a person was going through it. The third thing was, focus on parts of the ecosystem that are really fraught with challenges, especially around care coordination and service clarity, and not necessarily focus on survey coaching, right, at the end of the day. And then 4, use those engagement signals to guide the timing, the tone, and the outreach in gaps in experience, right? So for example, when we think about, gaps in experience, we know annual wellness visits are pretty much a predictor of overall experience. You get more people to do annual wellness visits, your CAP scores should increase overall. Urgent care versus ED, emergency visits really are proxies for getting care quickly and needing care. So when I think about it, it's, how do you make CAPS much more HEDIS-like and try to close those CAPS gaps at the end of the day? But that takes, looking at those signals to predict what do we think, and to forecast what do we think that member is going to go through. And then, Mike, as you're talking, ANOC communication, and with this plan, they really wanted to get ahead, kind of similar to what you were saying, of getting ahead in the communication. So not only, in the fourth quarter, do what you have to do from a regulatory perspective, but then follow up with, bi-directional communications. Ask the member, did you get it? Did you read it? Do you have any questions? And then first quarter, predicting from, when a member is going to go get, their meds, typically right January, February, right before the CAP season. And since who are the ones that are going to get most impacted from co-pays, all those other different changes that are going to occur, send out those communications, say, understand you're going to go, get your fills. Are you sure, are you aware that this is what's going to happen when you see it, right? When you go get it. And as a result, they had pretty much like a 60% engagement rate in terms of email and follow-throughs, 15% bi-directional communication engagement, wanting more information, making sure that they really understood what was going to happen. And, getting that call back from the plan within 24 hours to get that specific help. So, at the end of the day, members were engaged with what they were going to be going through. They were really much more actively involved. Those pulse surveys that they do as well, we're starting to show improvements, and ultimately we'll see it in the real CAP scores, right?
Yeah.
But being able to leverage those signals, being able to drive those communications, and being able to, ultimately have that enhanced understanding with those members was really critical.
Makes total sense. Another great story. I'd love to ask you some follow-ups, but we've got 4 minutes. I want to bring Brendan in for one more question. So I think, Brendan, what I'm hearing ever since we shifted the conversation towards CAPS is this underlying insinuation of how important it is to empathize with your member population. And it's such an important skill. We do shows on it, but empathy as a strategy is so critical. And it's easy to talk about it, but it's hard to execute on it. And I'm curious how Johns Hopkins Health Plan is applying this approach of empathy to how you're engaging in closing gaps in care.
Sure. Yeah. So this is something that
And by
is
the way, we
incredibly
got 4 minutes left. No pressure.
yeah, easy. This is something incredibly important to me and to Johns Hopkins as a whole. We always try to think about the member behind the ID card or behind the ID number and get into the soft and squishy, thinking about how our decisions impact friends, family, neighbor, you name it. So one of the ways that, I'm really enthusiastic about doing this with is we've created member personas. I'm sure many people on this call have, but we bring those member personas into many of our meetings. We have a member, Mary. Mary's 73 years old. She lives in Elkridge, Maryland. She goes to Giant Food Store. I can tell you her doctors. I can tell you that she's an Orioles fan and a painter. But her kids, have started talking with her about, maybe it's not that safe for you to drive anymore. Maybe some of these things that you've taken for granted are starting to change as you age due to your condition. And how do we, start interacting with people who are going through these life changes? I can tell you the way not to do it. The way not to do it is the way that many health plans do, which is we're going to reach out to Mary to tell her, hey, you need to get a colonoscopy and you need to get your eyes examined and you need to do this because I need to get my HEDIS rates up. There's a lot going on in Mary's life and she may not, want to do that. But if I could reach out to her and say, well, hey, there are transportation options that can get you to the grocery store. There are transportation options that can take you to the senior center where we know that you like to go and paint, and start to build around Mary as a person. If at the end of the day, I can't get you to get your colonoscopy, can't get you to get your eyes examined, but I did something to improve your life slightly. I did something that showed you a reason you can trust the health plan because we have your best interest at heart. In the long run, you're going to do those tests. You're going to get your HEDIS rate up. You're going to see that result in your CAPS and your Part D performance. But it's not always a series of gaps. It's taking those steps to help nudge a person along their healthcare journey, meet them where they are. And, if you asked anyone on my team about this Mary person, they'd be able to say, oh, yeah, here's how what we did yesterday impacts imaginary Mary.
Yep. It's good stuff. I could go on and on about how that important it is to connect you guys with the person. And that's a great final story. Thank you, all four of you, to your participation, your preparation for this. I know we were running a little bit long, so I had to jump around. You guys did great with all of that. I want to give a quick shout out to our producer for today's episode, Nicole Roberts, who put it all together. She should be thanked by everyone. And thank you to everyone listening and watching today. We do not take the time you spend with us lightly. We know you're super busy, whether you're watching this live or watching it via recording or podcast. We hope we use the ideas and the bright spots that were shared by our wonderful guests today to be applied at your organization and inspire your thinking wherever you are in this country. Each and every week, we produce this show for you. This is your Bright Spots in Healthcare podcast. Take care, everyone.